Yeah, please start. Yeah.
Good evening, everybody. Welcome. I think after some hiatus, we have restarted the online meetings, and hopefully, we should continue this from without any break. Salivary gland tumors are extremely important as far as I think understanding the salivary gland and its diseases are concerned, and also if there is a parotid gland or a submandibular gland that is visible or palpable in the exams, you could certainly get it. So I think understanding the salivary gland tumors and how you make a diagnosis and how you manage the patient is very important. And I think Indraja is going to take us through the salivary gland tumors. Over to you, Indraja, now.
Yes, sir. Good evening, respected teachers and my dear colleagues. I'm Dr. Indraja. Today I'm going to present on salivary gland tumors. I'm going to talk about different types of glands, anatomy, and the classification of tumors and their presentation and management. Salivary gland tumors constitute about 3 to 4% of the head and neck neoplasms. It is a rare group complex with heterogeneous histologies. Because of the tumor etiology and microscopic histology and different growth patterns and tumor characteristics, the diagnosis is a little bit difficult and the treatment is challenging for the surgeons. World Health Organization recognized about 24 different types of malignant salivary gland cancers. Salivary glands can be divided into major and minor. The major includes parotid, submandibular, and sublingual glands, and minor salivary glands, about approximately 750 glands, are distributed in the oral cavity. Based on their secretion, these can be divided into serous, mucinous, and mixed. Parotid gland secretes only serous secretion, and sublingual and minor salivary gland secretes mucinous secretions, and submandibular gland secretes both serous and mucinous secretions. Most of the salivary glands are seen in parotid glands, that is about 70%. Of these, 80% of the tumors are benign. And the tumors that are seen in the sublingual and minor salivary glands are almost always malignant, that is about more than 80 to 90%. Overall, commonest benign tumor is pleomorphic adenoma, and the commonest malignant tumor is mucoepidermoid carcinoma. Adenocystic carcinoma is commonly seen in submandibular and minor salivary glands. I'm going to talk about the anatomy of different salivary glands. Parotid gland, it is present in the parotid space and between the ramus of the mandible and sternocleidomastoid muscle. Deep cervical fascia, it splits to form superficial layer and deep layer and encloses the parotid gland. It has a large superficial lobe and deep small lobe that is separated by the facial nerve. The duct drains through the Stenson's duct that pierces the buccinator muscle and opens near the upper second molar. And occasionally, the gland has accessory lobe that present anterior to the superficial lobe and the masseter muscle. There are several important structures that run through the parotid gland, and these structures we should be careful during the dissection of the parotid gland. These includes facial nerve that divides into 5 main branches, and external carotid artery that divides into terminal branches of superficial temporal artery and the maxillary artery, and the retromandibular vein and the intraparotid lymph nodes. Submandibular gland, it present beneath the tongue. It has large superficial and small deeper lobe that continues around the posterior part of the mylohyoid muscle, and it is enclosed by the deep cervical fascia, and it drains through the Wharton's duct. It opens near the sublingual papilla under the tongue. And the anterior facial vein and artery are runs over the anterior surface of the gland, and the deeper part of the gland lies in close relation to the hypoglossal nerve and the lingual nerve. The important anatomical relationships of the submandibular glands are lingual nerve, hypoglossal nerve, anterior facial vein, and facial artery, marginal mandibular branch of the facial nerve. These are at risk during the submandibular gland dissection. Sublingual gland, it is present beneath the sublingual fold. It has a head portion that drains through the numerous ducts into the oral cavity, and the tail portion which drains either into the submandibular gland or directly into the oral cavity. There are about 750 minor salivary glands that distributed in the mucosa of the lips, cheeks, palate, and floor of the mouth and retromolar area. And sometimes these are also appears in the oropharynx, larynx, and trachea. Can I continue, sir?
Yeah.
Yes.
And any questions? I can't see any question in the this one, the chat box. Continue.
Sorry, Indraja, while
Yes, sir.
you're talking about the anatomy, are you talking about the surgical landmarks now, or are you going to cover it later on during surgery?
No, sir.
Because the idea of anatomy is to understand, where you have to be careful and what are the landmarks for preserving these structures.
Yes, sir.
Are you covering it later on when we do surgery, or not
No, sir,
talking about
I
it?
didn't mention about
Okay,
the
let us
surgery.
discuss it when you reach the surgical part. Yeah, go
Yes,
ahead.
sir.
Go on.
Okay,
Go on.
okay. And the risk factors and histogenesis of the salivary gland tumors. There are several risk factors that are associated with salivary gland malignancy. These include exposure to the Epstein-Barr virus and HIV infection, ultraviolet light exposure, occupational exposures in rubber and nickel industries, therapeutic radiation to the head and neck cancers, most commonly associated with mucoepidermoid carcinoma and primary squamous cell carcinoma, and autoimmune conditions like Sjogren's syndrome is associated with lymphoma of the salivary glands. There are several molecular pathways and oncogenes involved in the salivary gland malignancy. And mucoepidermoid carcinoma, it is most commonly associated with mucoepidermoid carcinoma translocation 1 gene and also amphiregulin gene. And fibroblast growth factor receptor is associated with acyclic cell carcinoma. And phosphoinositase 3 kinase is associated with salivary duct carcinoma. This is the fully developed salivary gland duct anatomy, which is showing secretory and non-secretory cells. Secretory cells includes mucus and serous cells, and non-secretory cells are myoepithelial cells. And the duct system include intercalated, striated, and excretory ducts. Myoepithelial cells are useful for the excretion of the saliva into the duct system. There are several theories that proposing the histogenesis of the salivary gland tumors. These includes basal reserve cell theory, unicellular, bicellular, and multicellular theories. The most accepted theory is bicellular theory of origin. According to this, mucoepidermoid carcinoma, primary squamous cell carcinoma, and salivary duct carcinoma arises from the excretory duct. And basal adenocarcinoma, adenocystic carcinoma, and acinic cell carcinoma arises from the intercalated duct. Adenocarcinoma not otherwise specified, it can be arises from either of these cells. Classification of the salivary gland tumors. This is the simplified classification of the salivary gland tumors, which includes adenoma, carcinoma, non-epithelial tumors, lymphomas, and unclassified tumors. The most common benign tumor is the pleomorphic adenoma, and the most common malignant tumor is the mucoepidermoid carcinoma.
Just go back.
Yes, sir.
Because we are talking about the risk factors, and
Yes,
you
sir.
mentioned Werthin's tumor, that is adenolymphoma, for the first time here.
Yes, sir.
Is there a risk factor for Werthin's that you have not mentioned earlier? Anybody else?
Sir, smoking, sir.
Correct.
Yes.
Correct. Smoking is
Yes,
a definite risk factor for Werthin's. Yeah, go
yes.
on.
Okay, sir.
I think sir's question is very relevant. Apart from that Werthin's tumor, they've tried to associate all other parotid or any other salivary gland tumors with smoking, just because smoking is a significant risk factor for all other oral malignancies, but it doesn't seem to have contributed anything to the malignancies apart from Werthin's tumor.
Yeah. The other interest. Sorry, go on.
Yes, sir. Yes, sir.
The other interesting thing about Werthin's is that earlier, during my student days, for example, it was considered a predominantly male tumor. It was male preponderance of 7 or 8 times that of females. Now it is almost equal, and that is attributed to a more common smoking pattern among women as well. That's another interesting thing about Verdens. Yeah. Go on. Yeah.
Yes. And as I said before, salivary gland tumors most commonly seen in parotid, but the malignancy rate is about 10 to 20%. But the tumors that are seen in sublingual and minor salivary glands are almost always malignant. And there are several histological types of the salivary gland tumors. These include benign and malignant. Among us, benign, most common is pleomorphic adenoma, followed by Warthin's tumor. And in malignant, mucoepidermoid carcinoma is most common, followed by acinar cell carcinoma. Pleomorphic adenoma, it is a benign mixed tumor. It is consists of both epithelial and connective tissue components. It most commonly seen in parotid, mostly in the superficial lobe. And females, it occurs in females compared to the males between 3rd to 5th decade of life. And in 10% of the cases, it can affect the deep parotid lobe. And this is the image showing the epithelial component in the chondromyxoid matrix of the pleomorphic adenoma. And adenolymphoma, it is the most common benign salivary tumor, mostly located in the tail of the parotid. Males are mostly common, sir, but you said it is all equal, so almost equal.
Yeah, just look at some of the recent papers on it, okay?
Yes, sir. Okay, sir.
Maybe I'll attach a paper to for all of you to read. Yeah, okay.
Okay, sir.
Right.
And it can also present as bilateral in about 7 to 10% of the cases. And the histopathology, it has a cystic spaces lined by the oncocytic columnar and cuboidal cells in the lymphoid stroma. Mucoepidermoid carcinoma, it most commonly seen in parotid gland. Histologically, it has mucin secreting cells and intermediate cells and epidermoid cells. The histological grade is predictive of tumor behavior. It can be divided into low and intermediate grade and high grade. Low grade tumors are asymptomatic and slow growing masses, and the surgical resection with negative margin is the treatment of choice. And the 5-year survival rate is about 80 to 90%. In case of high grade tumors, they rapidly increases and causes pain because of the involvement of the nerves, and there is increased risk of loco-regional and distant metastasis, and it has poor survival of about 40 to 50% at 5 years. Adenocystic carcinoma, it constitutes about 10 to 22% of the malignancies. Most of the patients are asymptomatic, but pain may present because of the involvement of the nerves. It has 3 types: cribriform, solid, and tubular type. And tubular type is associated with best prognosis. Solid type is least common but more aggressive. And the overall survival rate is 90%, 80%, and 70% at 5, 10, and 15 years. The histological picture shows pseudocystic spaces often filled with basophilic glycosaminoglycans. Acinic cell carcinoma, it involves most commonly parotid gland, but infrequently involves the nerves and regional nodes. The overall survival rate is 97% at the end of 5 years. This, in case of acinic cell carcinoma, it has evident nucleoli, and the cytoplasm can range from basophilic granular to eosinophilic cytoplasm. It is periodic acid positive and diastase resistant. Primary squamous cell carcinoma, it arises from the metaplastic ductal epithelium of the salivary gland, and it is rare, most commonly seen in men, and most of the patients present with pain and nodal involvement at the time of presentation, and the outcomes are poor. Overall survival rate is about 50% at the end of 5 years.
Okay. Wait, Indraja.
Yes, sir.
Pawan, are you there?
Yes, sir.
So any questions so far?
No, sir.
So I will ask you 2 questions. Which is
Yes.
the commonest tumor arising from the submandibular salivary gland?
Sir, mucoepidermoid.
No, not mucoepidermoid. You didn't listen properly.
Sir.
And which is the tumor which is bilateral usually?
Sir, Warthin's tumor, sir.
Yeah, this is one of the MCQ questions. Yeah, it's a bilateral tumor. The commonest tumor from the submandibular is adenoid cystic carcinoma.
Okay.
Okay. Anybody else? Any questions so far? Have you understood everything? I think the histologic details. I think probably we should leave it to our histologist or pathologist. But the important thing to understand is that the majority of the parotid gland tumors are benign. Majority of the smaller salivary, the sublingual and the minor salivary gland tumors are malignant. The submandibular is 50-50. So if you see a lump in the submandibular gland region, you still have to be very careful because it is likely to be malignant, as likely to be malignant as it is benign. But other thing you have to understand is that you can't ignore a pleomorphic adenoma, especially long-standing ones, or recurrence. Recurrence is a common phenomena with about 10 to 15% of pleomorphic adenomas recur. And the recurrent ones, you have to be careful because malignant transformation is about 15 to 20% in them. On the whole, all pleomorphic adenomas, if you take them, about 10 to 15% of them will be malignant. So you can't ignore pleomorphic adenomas. As the size increases, there is increased chance of it becoming malignant. As the longevity of the tumor increases, the increased chance of malignancy. Even though they are asymptomatic, if they have been long standing, you are well within your rights to advise resection for the risk of malignant transformation. So, Lakshman sir, anything to add, sir?
Nothing really. Go on.
Okay, carry on.
Yes, sir. And presentation of different glands, different salivary gland tumors. Parotid gland, presented as large fixed preauricular masses and limited mobility and fixity to the skin suggestive of malignancy. And the facial nerve involvement can seen up to 12 to 15% of patients. Submandibular gland lesions may present as painless neck masses in the submandibular triangle of the neck. Film lobulated and fixed masses and paralysis of the either of lingual hypoglossal nerve indicates the malignant lesions. Sublingual gland, it present as painless ulcerated mass in the floor of the mouth. About 50% of the cases can present with pain. And minor salivary gland tumors may present as submucosal oral swelling with ulceration. And if they are present in the nasopharynx, bleeding may occur, and the tumors in the pharynx or larynx may cause dysphagia and odonophagia. Yes, sir.
Indraja, you
Yes.
mentioned one or two issues as possibility of cancer, malignancy.
Yes, sir.
Can you add to that? Can you be a little more detailed?
Sir, regarding which gland, sir?
You have to mention each of them.
Okay.
Start with the parotid.
Sir, parotid.
You mentioned fixity to skin.
Yes, sir.
And facial nerve involvement.
And most of the unable to open the jaws or trismus, sir. That also.
Very, very rare. Very rare.
And nodal involvements.
Yes. Regional nodes,
yes.
rapid increase in size.
Yes.
All right. That's a very important thing. And pain.
Yes, sir.
Pain not necessarily means one of the you may say you can have pain even with hemorrhage and necrosis, but it can also be with infiltration of nerves. Okay. And hemorrhage and necrosis also is more common in a malignant tumor than in a benign tumor.
Yes, sir.
And so these are the 4 or 5 points that must get your antenna up, that a given lesion may be
malignant.
Yeah.
Yes,
Go on.
Sir. Yes, sir. When coming to the diagnosis of the lesions, ultrasonography is the first initial investigation of choice, and it is non-invasive and cost-effective. It is most useful in superficial parotid lesions. It localizes the tumor and it differentiates between the solid and cystic collections. And it also guided the fine needle aspiration biopsy. On ultrasonography, malignant neoplasms may appear as with irregular shape, irregular borders, and blurred margins, and hypoechoic inhomogeneous parenchyma. This is the image of the pleomorphic adenoma, which is showing well-defined lobulated tumor with hypoechoic lesion and posterior acoustic shadow, and it also contains the calcifications. And this is the image showing the ultrasonographic image of the Warthin's tumor, which is oval, well-defined tumor, hypoechoic, and it also contains multiple anechoic areas.
One sec.
Yes, sir.
When
Yes,
you're
sir.
looking at differential diagnosis, you must also look at the, you have cystic like spaces in the tumors as well.
Yes,
I know you're discussing tumors, but what
yes, sir.
are the other non-tumorous cysts that you can get in the salivary glands? Because they figure as your differential diagnosis. Pavan, cystic lesions, large lesions at sometimes, which can confuse you, particularly on ultrasound, as a differential diagnosis for tumors. Have you heard about silectasis?
Yes.
What is that?
So, because of the obstruction of the gland, sir.
Not necessarily obstruction. Yeah.
Local dilatation.
Yeah. It can be segmental. It can be universal. It is probably congenital. So you can have like some of them with time can go on to big spaces. Do you know of anything that happens in HIV, particularly in the peak of HIV? We used to see those. Parotitis, of course, was very common in HIV because of their immunosuppression. But along with it, there's something very characteristic about HIV, and that was large cystic dilatation of the parotid gland. Okay.
Yes, sir.
Nowadays, you don't see too much, HIV, but in the late 90s and the first decade of the year 2000 up to 2010 or 2015, we used to see these large spaces, large cystic cystic lesions of the parotid, and they do not look very much different from what the Werthin's tumor that you're showing. Of course, there won't be any solid element in it,
Yes,
but
sir.
that's a differential diagnosis that you must have in mind.
Okay.
Okay, yeah.
Okay, sir.
Because even neoplasms are more common in the immunocompromised.
Yes, sir. Okay.
Okay. What neoplasms are more common? Lymphoreticular diseases. Okay, lymphoma
Yes.
of the parotid you can get
Yes,
in
sir.
an HIV patient. Yeah, please go on.
Yes.
Yeah.
And the role of FNAC is controversial because sometimes.
No, it's not
Yes,
controversial.
okay.
Don't say.
Okay,
I
sir.
think the role of a true cut biopsy is maybe controversial because
Okay, sir.
potentially
Spillage of
there
the-
is one is seeding of the tract
Yes.
and involvement of the skin if it is not already involved, and also hemorrhage because of the vascularity of the gland, and third is nerve damage because the facial nerve and its branches, you don't know where they are, and if you do a deep true cut biopsy.
Yes.
But FNAC is well accepted as a mode of investigation. As you said, ultrasound guided FNAC is the investigation of choice.
Okay, sir.
In addition to the ultrasound itself, or if you are suspecting malignancy, I'm sure you will come to the other investigative modalities.
Yes, sir.
So ultrasound and ultrasound guided FNAC, clear
Okay.
message to all the students. There is no controversy about FNAC. It may not pick up all tumors, but certainly it is one of the investigative modalities that you have to use. FNA, the true cut biopsies, as Indraja said, may be more controversial.
Yeah.
Sir?
I have attached a 2016 guidelines.
Yes, sir.
And the apprehension that Ravi mentioned about true cut is very true.
Yes, sir.
And that's what they expect of you in the examination. But if you see the 2016 guidelines, he says true cut can also be done.
Okay.
Okay. But
Okay, sir.
but yes, the classic teaching still is, and I think this is what your examiners expect, that FNAC is okay and true cut, some reservation, some controversy. Definite no is, of course, an incision biopsy. Okay. That's not even done. So we'll come to that when we come to the treatment. Go on.
Yes, sir. Yes, sir.
Yeah.
And FNAC has a sensitivity up to 85% and specificity up to 99%. And if it shows malignant lesion, we can decide the extent of surgery and need for neck dissection preoperatively. And this is a reporting system, that is Milan system for reporting salivary gland cytopathology. It has 7 variables of non-diagnostic neoplastic atypia, benign, and a salivary gland neoplasm of uncertain malignant potential, and suspicious for malignancy and malignant. Based on this, we can report the FNAC, fine needle aspiration cytology reports. Then we can decide the treatment according to this. CT, it has a limited role in the evaluation of the salivary gland tumors. We can see the extent, bony infiltration and lymphadenopathy, but it has poor soft tissue resolution, especially in mucoepidermoid carcinoma and adenocarcinoma. Magnetic resonance image, it has higher sensitivity and specificity when compared to the CT in detecting perineural spread. Indeed, it is more useful in assessing deep parotid lobe, sublingual glands, and minor salivary glands, and also extent of the tumor, soft tissue invasion, and nerve involvement.
Yeah, I would, if you read these guidelines,
Yes, sir.
even though some standard books tell us what you have said, that
Yes.
CT is not very sensitive, you will see that CT is recommended there as an investigation of choice. Okay,
Yes, sir.
because
Okay, sir.
it can look at the extent. It can particularly be helpful if the deep lobe is involved, even though soft tissue definition, as you say, definitely perineural invasion, MRI is better.
Yes, sir.
But otherwise, CT is still the backbone of diagnosis, particularly to know the extent and deep extensions.
Yes.
Okay, yeah,
Yes,
go
sir.
on.
And I think what you said about the magnetic MRI being the imaging of choice, especially for the minor salivary gland tumors.
Minor, no questions. Yes.
No question. It is the investigation of choice.
Yeah.
So I think the other thing which you just mentioned in passing, but more important for everybody to know, is the nodal status. I think as sir said, nodal status still better, better delineated by CT compared to MRI, and involvement of the mandible. I think again bony involvement is very much more clearer on the CT compared to MRI.
Yes.
But your point about the facial nerve delineation and perineural infiltration is much better delineated by the MR scan is well taken. That is correct.
Okay, sir.
So for the students, you have to investigate this in an orderly fashion. Ultrasound guided FNAC, or if your department is skilled enough to do maybe an ultrasound guided true cut biopsy. If there is doubt about the diagnosis, I think you should first go for FNAC. If FNAC is equivocal, as she told about the Milan criteria, then if you still feel that you need a preoperative diagnosis, then you can go for a true cut biopsy under guidance, and then decide based on the clinical findings, examination findings, and the cytology and ultrasound, whether you need to get CT, MR, or both.
I would also add that if any of your examiners will raise questions about FNAC, then you can say that it is quite acceptable to even go for a regular surgery excision, and we'll come to the details of what kind of excision that you do, even without a cytological diagnosis. That is also acceptable. But it is the present thinking is that it is good to have the cytological definition, if possible, with an FNAC or a true cut.
Okay.
Go on, Indraja.
Yes, sir. And this is the MRI image showing the extension into the deep lobe. The role of PET-CT, it detects locoregional and distant metastasis. And compared to the CT, it is more accurate in demonstrating tumor extension, nodal involvement, local recurrence, and distant metastasis. But it can't differentiate between the benign and malignant tumors.
You may also add even inflammatory tumors.
Yes, sir.
Okay, inflammatory swellings, because PET-CT has that limitation.
Yes.
That it can light up even in some inflammatory conditions.
Okay, sir.
Yeah.
Yes.
So as of now, PET CT is not the standard of care
Yes.
as far as investigative modalities are concerned.
Yes, sir. According to the American Joint Committee of Association 8th edition, this is the staging system. T1 is tumor of 2 centimeters, less than 2 centimeters, and T2 is more than 2 centimeters but less than 4 centimeters, and T3 is more than 4 centimeters, having extraparenchymal extension. T4A is tumor invades the skin, mandible, ear canal, or facial nerve. And 4B is very advanced disease, invades the skull base and pterygoid plates and or encases the carotid artery. Coming to the nodal involvement, L1 is metastasis in single ipsilateral lymph node that is less than 3 centimeters. 2A is single ipsilateral lymph node more than 3 centimeters but less than 6 centimeters. 2B is multiple ipsilateral lymph nodes not more than 6 centimeters. 2C is metastasis in bilateral lymph nodes but not more than 6 centimeters. And N3 is any lymph node more than 6 centimeters in greatest dimension. Management.
Stop for a minute.
Yes, sir.
Any questions so far from the students? Have you understood the clinical examination investigations and coming to the diagnosis and staging of the salivary tumors? Any questions from students? Think you need to participate more actively. Abdul, are you there?
Yes, sir.
Anything to add?
No, sir. Nothing else.
Pooja?
All points are covered.
Pooja?
No, sir, she's covered all points almost.
Okay, right. Carry on.
In case of submandibular gland tumors, it is benign. We can go with wide excision, that is excision of the submandibular gland and follow-up of the patient. In case of malignant tumors, we should remove the gland with neck dissection. In case of N0 neck, we can observe or we can go for the elective dissection or prophylactic radiation. But in case of high-grade tumors that are T3 or T4, we should do the elective neck dissection. And primary radiotherapy may be applicable in case of inoperable tumors where palliation can be achieved. Sir, my doubt is N0 neck whether to do elective dissection or not.
Abdul, what do you think we should do?
Sir, it depends on where the source of cancer is.
No, so submandibular gland. She is now talking about submandibular gland.
Submandibular gland, then no need, sir, for elective neck dissection.
Why?
Because the ipsilateral spread, no, sir. But so N0 neck, clinically N0 neck, there is no need for neck dissection.
Have you checked the NCCN guidelines about this?
Sir, I studied like American Society of Clinical Oncology, sir.
Okay, what do they say?
Yes, sir. They said like N0, we no need to do, we can observe. But in case of high-grade tumors,
That is the point. I'm
yes,
glad you have read that.
yes, sir.
That is the real answer. So whether you do a prophylactic dissection depends on two factors: size of the tumor and the grade of the
Grade of
tumor.
the tumor.
Okay, if it's a big tumor, even though it may be clinically N0, you do that. And more importantly, if it's a high-grade tumor, it is better to do an N0, do a neck dissection even in an N0 neck. And I think that's what the guidelines show. You know, the one I have attached.
Yeah.
I think that also mentions that. Yeah.
Yes, sir.
I think the other thing what I think sir said is very true. The main thing is that salivary, the submandibular, sublingual, and the minor salivary gland tumors behave much worse compared to the parotid.
Parotid.
So you have to be more careful. You probably are on the side of doing the neck dissection, especially size and the grade of the tumor, even though clinically and radiologically it may be node negative.
And they are telling like nodal involvement is more in the submandibular tumors when
Correct.
compared to the
That is why.
peripheral.
That is why.
Yes, sir.
Exactly. That
Yes.
same reason you are probably see because sentinel node has not yet come into play in this. They are trying out, but I think at the moment the current recommendation is that even with clinically neck this one nodal negativity, you are probably advised with larger tumors and more high grade tumors to do a prophylactic neck dissection ipsilateral.
Sir,
Okay.
yes, sir. Sir,
Yeah, continue.
we have to do ipsilateral or bilateral, sir?
Why bilateral?
Bilateral. Okay. I just-
Question of
Ipsilateral.
Yes, sir.
question of bilateral doesn't arise.
Okay, sir.
Yeah.
Okay.
Yeah.
And complication related to the submandibular surgery includes hematoma and wound infection, injury to the mandibular, marginal mandibular nerve, lingual and hypoglossal nerve, and transection of the nerve to the mylohyoid results in the submental skin anesthesia.
Okay, you need to know a little bit more about it. So how
Yes,
do you
sir.
avoid these things? How
Sir,
to avoid a marginal mandibular nerve injury?
Sir, the nerve is passes along the angle of the mandible, sir. So we should give the incision at least 2.5 centimeters above the angle of the mandible.
Okay.
Yes, sir.
And what is more important? I mean, equally important, if not more important. What is the plane of that nerve? Is it deep to the deep fascia or superficial to the deep fascia? Just tell me that.
Sir, I'm not sure.
You must be.
Sorry.
You've seen the nerve coming out of the parotid, no?
Yes, sir.
And it comes and supplies the facial muscles, right?
Yes, sir. Yes.
Orbicularis, oris.
Or-
So
yes.
where would it be?
Superficial to the
Yeah, it would
deep
be, it's
fascia.
a relatively superficial nerve.
Superficial
So
to the yes,
not
sir.
only do you make the incision 2 centimeters away from the angle of the mandible, you also go straight down deep to the deep fascia, cut right down in the line of incision and enter to a plane which is deep to the deep fascia.
Yes, sir.
That way you avoid an injury to the nerve. If you're sort of dissecting laterally and you stray nearer the angle of the mandible, in a more superficial plane, the nerve is at a greater risk for damage.
Yes.
That's an important thing. Yeah, go on.
Okay. Yes, sir.
Yeah.
And in parotid gland tumors, in case of benign tumors, we can do superficial parotidectomy. If there is intraoperative spillage of the tumor, we can consider adjuvant radiotherapy after discussing with the team. And in case of malignant tumors, if it is low grade T1 or T2, some some people are doing superficial parotidectomy and most of the people are doing conservative or radical parotidectomy if the nerve is involved. And in case of high grade tumors, those are T3 and T4, conservative or radical parotidectomy with elective neck dissection should be considered.
All right. So,
Yes, sir.
okay, go on, Ravi. Go on. Go on.
Yeah, now describe the process of the parotidectomy. I think this is where sir was asking you about the anatomy in relation to surgery, the surgical anatomy or the applied anatomy.
So first we have to give the incision that is called Lazius incision, sir. It in the preauricular area and mastoid and below the lower part of
Have
the
you seen parotidectomies?
one size.
One. Okay.
Yes.
Okay, go on. Go on. Yeah.
Then we have to raise the flaps.
Yes, carry
Yes.
on.
Yeah.
So after you raise the flap, the parotid gland comes into view. So then what do you do next?
So initially we'll encounter the like a greater auricular nerves are in the superficial plane. So we have to transect the greater auricular nerve and then we will go to the deep dissection, sir.
Okay.
We can create, there are two avascular planes, sir.
Carry on. We are not stopping you. You carry on talking. Okay.
Sir.
Now,
Okay.
if you are not sure, Pawan, can you take over? Can you tell us about the parotidectomy?
Sir, after raising skin flaps, we have to identify the facial nerve, that is the retromandibular vein is there, sir.
Ah.
So we will identify the
Which are the many ways described to identify the facial nerve?
sir. One is in front of the tragus, sir.
Yeah, what is that
The
called?
trunk colony
Tragal
point.
pointer. The
Point.
tragal pointer. Okay.
Tragus point. Yes, sir.
Okay. Then
Another one is at the insertion of the posterior belly of digastric, sir. Posterior insertion just above that.
where does it get inserted to?
Sir, mastoid, sir.
Okay. Then
Another one is stylomastoid.
the styloid process.
Styloid processes, sir.
Then as you said, the retromandibular vein.
Yes, sir.
That's a very important landmark. Okay. Abdul, or let us ask Pooja. Pooja, have you seen parotidectomies?
No, sir. Actually, no, I've not seen
Is it
one.
not common in Northeast?
No, sir. I've actually not seen one. Parotidectomy.
All
Okay,
right.
so let us go to Abdul then. Abdul,
Yes, sir.
yeah, go on, describe the parotid.
So once you identify the main trunk of the facial nerve, so
That
the
is how
dissection-
do you,
How
Abdul?
do you identify?
That is the crucial
No,
point.
the
How do you
tragal
identify?
pointer, so you go deep to the tragal pointer. You
Okay.
identify the main trunk, and from there you start isolating, going
What is-
superficial.
What is the direction of the main trunk? As you go deeper into the tragal point, what are the things that you can cut confidently, and what are the things you should be careful about? That is a point you need to know. What is a tragal point? First tell me that. That has not been defined yet. It is 1 centimeter in front of and inferior to the tragus.
Yes, sir.
All right. And the tragus, the only objection to this is that the tragus is a mobile structure.
Structure, yeah.
So how do you overcome this? So at the tragus, okay, you have dense fibrous tissue which is horizontal. You know, it is parallel to the surface of the operating table or the floor. Okay, you can cut those and find the cartilage which is under, the external auditory meatus. One part of that area you will see when you cut these dense fibrous tissue that connects the parotid to the ear, to the tragus, and the area deep to the tragus. These horizontal things, which fibrous tissue that you have, can be cut with impunity because the nerve comes at you vertically. You understand? So beginners find it very difficult to cut those tissues, and so they'll be digging around, looking for the nerve and never find it because they don't cut these tissues. So you have to cut these and get into that area, which is about 1 centimeter in front of and inferior to the tragus. Then you'll find the nerve coming up at you, towards you. Okay, it's almost vertical to the floor of the table, to the table or the floor of the room. So it comes in that direction, and it is covered by the parotid gland around it. It's not that it will stand out like that nicely. The other pointer that tells you that that is the nerve is that when you feel with your finger deep down, you will find the base of the styloid process. Okay, because the nerve curves around the styloid process. And the third point is that if you sort of palpate it sideways, not vertically, you will find that the parotid tissue and the nerve which is entering the parotid will have a different different texture to it. So you can see that that is a thread-like tissue. That is the nerve with the parotid, a bit of parotid covered over it. So that is how you identify the trunk of the nerve. What do you do then?
So
Okay.
you have to.
Take a nice blunt tipped right angle forceps, 6-inch, not a big one, and then separate the parotid tissue over the nerve. You sort of tease the parotid tissue away from the nerve, and you can then the nerve becomes a little more prominent, little more obvious, and then the only time you're sure that you're dealing with the nerve is when you get this process maybe for a centimeter and a centimeter and a half, and show the superior and the inferior branches of the nerve. That's when you know that you have really identified and preserved the facial nerve. Okay, Ravi, anything to add?
No, I said that's the two things, zygomatico-facial and zygomatico-temporal branches, and it becomes a bit broader as Sir said, as it emerges out, and then when it becomes broader, then you see the pes anserinus or the 5 branches of the foot, like the crow's foot or whatever it's called, pes anserinus. I think the other thing that you can tell if you want is, especially in patients who have redo surgeries and things, the anatomy may not be that obvious. You can use the facility if you have of a nerve stimulator. And if you have a nerve stimulator, you can use it to identify the facial nerve.
Yes.
Is there any other way of dealing with the facial nerve and trying to preserve it? One approach, as we described, is to identify the trunk. Can you do anything else about it?
Can come
Okay.
from
Retrograde dissection also.
Yes,
Yes.
that is
Yeah.
also possible. Okay.
Yes, sir.
Yeah.
Can I continue, sir?
Yes, you can.
Yes. Sir. And yes.
See, again, I think the facial nerve is an extremely important structure, and unless it is seen to be infiltrating and the tumor is high grade tumor, you can still you can still spare the nerve, and then if there is any kind of residual, maybe on the histology, if there is any residual tumor, you can consider giving them radiotherapy. So that way you have achieved oncologic clearance and also retained the facial nerve. But if it is obviously infiltrating and if it is a high grade tumor, then you are well within your rights, provided you have actually taken a proper consent where you say that the facial nerve is going to be sacrificed and the patients are aware that it is going to happen. Then you can do a radical parotidectomy with the facial nerve as well.
Yes. In complications related to the surgery includes hematoma formation, infection, and transection of the facial nerve that leads to permanent facial weakness, and numbness of the earlobe because of the transection of the greater auricular nerve, and the Frei's syndrome. Frei's syndrome, it is also known as a gustatory sweating. It is because of the after parotidectomy, the secretomotor fibers of the auriculotemporal nerve also involve the skin over the parotid region. So that's why when patient is having food or smell it, he starts having sweating in that region.
Continue.
Yes, and indications for neck dissection. Cervical lymph node status is an important prognostic factor, and it should be undertaken if there is any clinical or radiological evidence of the nodal metastasis. If the risk of occult nodal disease is more than 15%, then we can consider the elective neck dissection. But it is important that there is no evidence that elective nodal dissection for malignant salivary histologies confers any survival benefit. Indications of postoperative radiotherapy includes high tumor classification, high-grade histology, and positive surgical margins, perineural invasion, and nodal metastasis. Adjuvant radiotherapy has survival benefit in patients with locally advanced malignancy with improved regional control. Chemotherapy we can consider in treating metastatic, recurrent, and unresectable salivary gland tumors. And the cisplatin is the current single most agent can be used. And the combination therapies are also coming. Those includes 5-fluorouracil, cyclophosphamide, and doxorubicin. But the still studies are going on regarding the chemotherapy. And
And what
targeted.
is
Yes, sir.
what is other chemotherapy that is coming on quite strongly? Tyrosine kinase inhibitors.
Yes, sir. Okay.
Yeah, I think she's, yeah. Go on, go on.
Yes, sir. And more recently, targeted therapies are also coming. These targets against the epidermal growth factor receptors, HER2 protooncogen, c-KIT protooncogen, and vascular endothelial growth factors. But the no target therapy agent has been found to be effective till now. This is the algorithm showing the management of the salivary gland tumors. If it is benign, we can go for the surgery and we should follow up the patient. If this is high-grade malignancies, we should work up for the metastasis. If it is resectable, we can consider surgery followed by post-operative radiotherapy and follow-up of the patients. Follow-up, the locoregional and distant recurrence at 5 years after completion of the treatment can vary widely because of the diverse range of the histological types and wide range of clinical behaviors. And the recurrence also varies based on the pathological grade and stage of the tumor. We should follow up the patients quarterly for first 2 to 3 years, followed by 6 monthly for 5 years. Then yearly visit should be recommended. So in conclusion, in case of salivary gland tumor.
Wait. Where is it that you consider chemotherapy as a primary mode of treatment?
Like inoperable.
But it is not very helpful, as you said yourself. In those inoperable tumors, you're more likely to have some reasonably good result with radiotherapy than with chemotherapy. But there is one instance where you would consider chemotherapy as a primary mode of treatment. May not even need to do surgery in those people. Anybody?
Lymphoma, sir.
Lymphomas. So any lymphomas that is arising, as sir said, in patients who have immunosuppression, or in patients with Sjögren syndrome, where lymphomas are more common. If you have the histology of if it being lymphoma, then I think you can just give them chemotherapy followed by radiotherapy if indicated, if there are nodes positive. Yes. I think that will suffice. You may not need surgery in that situation.
Yes.
Okay.
Indraja,
Yes,
I don't know if I missed it, but I don't think I did. You never mentioned about what you would do if you have a malignant tumor with a facial nerve involvement without metastasis. We are looking at local disease, no metastasis, facial nerve is involved, or even if it's not clinically involved, when you're operating, you'll find this tumor, which is malignant, is so closely surrounding the nerve that you cannot separate it. What do you do?
Like we can resect and we'll use grafts.
You can't even graft because your long length of the nerve will be gone. This graft and primary suture is for when you recognize the facial nerve being cut inadvertently. Yes, here, you do not hesitate to sacrifice the seventh nerve, the facial nerve. In fact, you would have taken a consent about it. Yes, sir. And do not, particularly a suspected malignancy, you do not promise that you will preserve try to preserve the seventh nerve. You can preserve it and do it. Yes. The other thing is, what do you do if the tumor is in the deep lobe and not in the superficial lobe? A well-differentiated tumor up to T2, which is in the superficial lobe, superficial parodectomy is adequate. Yes. But suppose it's coming from the deeper lobe, well-differentiated. What do you do? So you end up doing a total parodectomy, right? But yes, what do you do with the seventh nerve?
To preserve it.
Yeah, you can actually isolate it, put strings around it, you
Yes.
know, tapes around it to preserve it, lift it off the deep lobe, and then with the facial nerve preserved and lifted, you
Yes, sir.
can clear the deep lobe with the contained tumor also. It
Okay.
is quite possible to do that. Okay.
Yes, sir.
Yeah. And point all of you must remember is that when there is malignancy, err on the side of giving adjuvant radiotherapy. Even though you have clear-cut margins, good to have adjuvant radiotherapy. And it is definitely indicated when there is a high-grade tumor, or if your margins are not very complete, are not clearly free of tumor. When you suspect that perhaps your margin is not adequate, then definitely radiotherapy is a must, and you must err, as I said, even in the well differentiated tumors, low grade tumors, better to err on the side of malignancy, because when the recurrence occurs, dealing with it is a lot more difficult than dealing with the primary tumor, the first go at the tumor.
Yes.
Okay. Yeah.
Yes.
That these are practical issues that you get an algorithm and they say that, but at the end of the day you have to decide for the patient what you're doing, and these are practical. These are standard of care accepted.
Yes, sir.
Okay. I have attached a few pictures for you to see.
Yes,
My
sir.
operative pictures. I've given you those two papers. Read that, and another couple of links to papers to tell you how to identify the root of the seventh nerve. These
Yes,
are
sir.
very, very useful pointers. Please use that. And when you see the pictures, you will very clearly see what I meant by saying that the seventh nerve comes vertically at you
Yes, sir.
with the patient's head turned. Otherwise, you can actually appreciate it in the picture itself. Just have a look at it. Okay.
Yes, sir. Okay,
Yeah.
sir. Okay.
Yeah. Yeah.
Okay, sir.
Any questions?
Take home message. Yeah. What is
Yeah,
the take
go
home
on.
message?
We should evaluate the patients preoperatively by imaging and fine needle aspiration, and we should decide the proper surgical procedure, and after that we should advise the patient like post-operative radiotherapy and follow-up of the patients.
I thought the title of this talk was salivary gland tumors, right?
Yes, sir.
So you have not covered any of the benign tumors at all. In fact, as we said, 80% of the tumors are benign.
Benign. Yes, sir.
So we should,
She briefly mentioned pleomorphic adenoma.
yeah, but yeah. Anyway, so it's okay, but you
Yes,
can
sir.
read up about these things.
Yes, sir.
I don't think we need a separate class for that, but it would have been nice if we had covered that. Otherwise, good presentation, Indraja.
Yes, sir.
It is important for you to watch an operation. So
Yes,
when
sir.
there is something going on, be on the lookout and try and watch it, because whatever we say in description never can meet the learning process of actually seeing it with your eyes. Okay.
Yes,
Seeing
sir.
it, yeah.
Okay.
Yeah. Final comments, Ravi?
Yeah, I think the structure of her talk was good, and I think she presented it well. I think that you can see a significant improvement in her presentation skills. Slides were also well made, and I think it also missed my notice about. I think we should have spoken a bit more about pleomorphic adenomas. I think that was a probably mistake on my part as well.
No, not. It's
So
none of this is a mistake. I think it's just a
it's
question of
oversight.
Okay. Yeah.
Yeah.
Manoj
Okay.
writes about a convergence technique. You want to unmute yourself and talk about it, Manoj?
Yes, sir. Good evening, sir. Good evening.
Good
Good evening.
Sir, actually, as a beginner, I think looking out for the pointers and creating, I feel looking out for this one, the tragal pointer, we end up making a hole, like it becomes a tunnel. So it becomes difficult to, identify the facial nerve. So I through various online videos, actually, I started doing where I identify the digastric and its attachment from below. So once we do that dissection along with identifying the tragal pointer, I think the nerve will become very easy to identify rather than just creating a cavity to look out for the nerve, just looking for the tragal pointer. I think the dissection should begin with looking and identifying the digastric and tracing to its attachment to the mastoid. And as well from above, if we look out for the tragal pointer after that, I think the facial nerve would be easier to identify. And secondly, I think that we should save the branch of the greater auricular and sacrifice only the anterior one. The posterior one should be saved. And that's another thing which was missed out.
Yeah, fair enough. Yeah, great auricular, we should have talked about it. You're right. You're
Yes.
right.
Yeah.
This tunnel, the only comment I can make, Manoj, is that routinely we do it above and below to a good distance.
Okay, sir.
And so it's not a tunnel that we are looking at. Okay. And you will find that when we reach inferior enough, we will, as I said, you have to divide those tough fibers that go from the external auditory meatus onto the parotid. When you divide those for a good length above and below the so-called tragal pointer, you will invariably see the posterior belly of the digastric. And so you have another additional pointer, as you said, to look at the nerve. Yeah, fair enough.
Yes.
But greater auricular, point taken. Yes.
Yes. Thank you, sir.
Yeah.
Any other comments? Pooja? Hello? Pooja,
Sir,
any comments?
yes, sir. Nothing in specific, sir.
Okay, I think we all agree it was a good presentation. She's touched most of the points, and she was done in a very fluid and good manner. Good, well done, Indraja. So if there are no other comments, thank you all for attending, and good night.
Thank you,
Good
sir.
night. Good night.
Sir. Good night.